Well, it's great to be back at Rockefeller and back in Albany with so many of my friends and former colleagues. In some sense, this is really a good news, bad news story for all of you. The good news is, since I no longer have an official position, I don't have to mince words or be constrained in terms of what I say. Not that I really ever was, but now I really don't have to be. The bad news is I know more about what's going on in Wisconsin than I do in New York. But be that as it may, I'm going to take a look at health reform implementation and some of the issues that New York State and so many of you will have to address in the next 3 years to be ready for implementation in 2014. So, as Dick alluded to, the overarching rules for federal reform come from Washington, but implementation is all about the states. And states are doing this, and you know this much better than I do, at a point in time when there is no money, and states are facing huge budget gaps. And of course, New York is no different. So that between 2010 and 2014, New York must tackle cost containment and health reform at the same time. And we have to do it with fewer staff and less resources. So what I've done is I've picked out a number of the goals of health reform and tried to think them through in terms of New York State. What are the issues that we will have to think about implementing here in New York? And in some sense, we start in a better place than most states because we are one of the 5 states that provides Medicaid coverage to childless adults. And we already cover parents to 133% of the federal poverty level, the new national eligibility level. Many states only cover parents to 50%. So we have states that are going to have to address bringing hundreds of thousands or millions of people into public coverage for the first time in 2014. New York doesn't have to do that, but we do have to walk our system over to the federal rules and vice versa. So it really starts with looking at the federal rules and then applying them to each of the coverage options. Now, my next slide should not have been this slide. I should have done a slide right now about the exchange, because the exchange is the primary vehicle by which New York states and all states will make coverage accessible and affordable to individuals. And how we implement that exchange will determine how successful we are in achieving the coverage goals. And I submit to you that in the 2011 session, which is practically tomorrow, we will need to address the structure of the exchange in order to be able to demonstrate to the feds, as we must on January 1, 2013, that we will have a viable exchange and to make and effectuate all of those decisions. So that in 2011, because I believe if we push it to 2012 session, it won't be enough time. We will have to decide, will the exchange be a state agency, a nonprofit, a public authority? And once we make those decisions and we authorize an exchange structure in legislation, then we have a multitude of questions the exchange will have to confront as to how it operates. But until we have that structure in place, it is far more difficult to focus on the questions we will have to address. So the exchange will be the first issue. The second issue, and remember the goal I'm talking about is continuous coverage for consumers below 400% of the federal poverty level. Now, stepping back, we will have over 6 million New Yorkers eligible for subsidized coverage in 2014. Approximately 5 million, or really over 5 million, probably 5.5 million, who will be eligible for Medicaid or Child Health Plus, and another million who will be eligible to go into the exchange, about 700,000 of whom will be eligible for subsidies. So we are looking at over 6 million people who will go into the exchange to find out if they're eligible for a subsidy, whether it's 100% of Medicaid or a tax credit above 133% up to 400%, and select a plan. So when we think exchange, the biggest plan or plans in the exchange will be Medicaid, because Medicaid is both a subsidy and an insurance product. And in New York, we deliver Medicaid primarily through managed care plans. So those managed care plans will be in the exchange. So when you think about the exchange, you have, I know I'm myopic about Medicaid, and that hasn't changed, but you really can't think about the exchange without thinking about the largest product, the largest subsidy in the exchange, and that's Medicaid. So this step one, let's look at the national eligibility levels and crosswalk them to New York State. And the first column is where we are with Medicaid and Family Health Plus, which is Medicaid, and Child Health Plus, and then what comes in under the ACA. And there are two areas where we are below the 133% mandate. One is childless adults. We only cover childless adults to 100% of the federal poverty level. In 14, we will bring that up to 133%. I know it's really 138% because there's a 5% add-on because there will no longer be exemptions. But let's call it 133. So childless adults will bring up from 100 to 133. And children, at the bottom, between 6 and 18, we cover children above 100% through Child Health Plus. In 2014, we will move those children into Medicaid. In addition, we cover some adults above 133%. We cover parents up to 150%. We cover pregnant women up to 200%. And we cover 19 and 20-year-olds up to 150%. So we have three groups of adults where we are above 133%. So we are going to have to decide what to do about pregnant women above 133 and parents and 19-year-olds above 133. And in making that decision, we will have to consider the fiscal implications. Now, under federal reform, we will get 90% FMAP, 90% for all of our childless adults. So by 2019, we have about 1 million childless adults enrolled, and we will be getting, this is one of the rabbits we pulled out of the hat in Washington just before the bill passed. The federal government will be paying most of the cost of childless adults and all of the exchange costs. New York State will have no costs for individuals in the exchange. So if we determine to move pregnant women, parents, and 19-year-olds into the exchange at above 133%, we will be relieved of those costs, right? Because we're paying for them now in Medicaid. We move them into the exchange, and the federal government will pick up the cost through the subsidy. Now, I can argue this both ways. The benefit may not be as comprehensive, and the individual above 133 will pick up some level of cost. But maybe this is an appropriate choice for us to make, but this is in legislation. And you in New York State and you, my friends in the legislature, will have to make a decision about that in 11 or 12 so that we can implement it by 14. I mean, and I might argue to put it in 11, but I don't know how you're going to do everything in 11. So at least in 12, we're going to have to make that decision, and then we're going to have to get CMS approval, which often is harder than moving something through the legislature. So this is why these really are today's questions. And then we will have to think through. Remember, we're going to be moving adults from Family Health Plus or Medicaid into the exchange, potentially. We're definitely going to be moving children from Child Health Plus into Medicaid. And we're going to have to be sure that transition is smooth. And we're going to want to assure that to have continuous coverage in our exchange, the relationship between Medicaid, a basic health plan, if we decide to do it, I'll come back to that, and subsidized coverage and non-subsidized coverage, because people's incomes change. So we have to think through, and this is why I really believe we need to get that exchange up and running. How do we do this in a way that is efficient and effective? And remember, when someone comes into the exchange for coverage, they don't know, my income is 127% of the federal poverty level. Well, people don't know that. And they don't say to the neighbor, oh, I get Medicaid because I'm 127% and you're 147%, so you get an exchange subsidy. We have to set up an exchange that facilitates the flow of information so that individuals, whether they're 127, 147, or 347, can find out their eligibility for a subsidy and choose a plan. No small feat. Now, what's the benefit package? The federal law says that we will only get the enhanced matching dollars for childless adults for a benchmark benefit package. And if you look at the law, benchmark is tied to a number of different types of plans, but at the end of the day, benchmark is whatever the secretary approves. Now, there are a lot of states that I'm working in that are looking at how little they can put in the benchmark. And the federal law says you have to at least put the essential benefits that are in the exchange plans into your benchmark. But let's assume New York has never approached life that way. So what are we going to put in our benchmark plan? We could offer the full range of Medicaid services if HHS would approve it, and we have dollars to pay for it. We could say, no, we're only going to do what is the Family Health Plus benefit package, which is pretty close to Medicaid, but it doesn't have nursing home coverage. Or we could take it back further and we could say, let's look at what's in the essential benefit package, and that would mean no nursing home, no home health, dental, or vision. Now, let's assume, I could see New York deciding to put in our benchmark for childless adults, the Family Health Plus benefit package. Because remember, we're talking about individuals under 65 and non-disabled. So no nursing home coverage does not, should I go out on a limb, doesn't seem like an awful thing to pull out. Because if you're disabled or elderly, you're going to get full Medicaid. So then we're going to have a benchmark benefit for childless adults that's different from the benefit package for children and different from the benefit package for parents. In an effort to streamline and be efficient and to integrate Medicaid into the exchange along with the other plans, I might argue that maybe our benefit package for parents should not include nursing home coverage. I know that I may be shocked by some of my consumer friends, but maybe since you'll get nursing home coverage when you're 65 or disabled, maybe it's important to have one benefit package for all adults. For efficiency's sake, for continuity's sake, or not. But it's a fair question to ask. And whatever that decision is, it will have to go into legislation. And we can't decide it between the end of January and April 1st when we're doing the budget. We need to think about these things now and balance all of the different issues. So the federal law gives states the option of offering a basic health plan for individuals between 133% and 200% of the federal poverty level. And New York is considering this option. And if we take advantage of it, the federal government will turn over to us 95% of the subsidies that are available to individuals between 133 and 200% of the federal poverty level. And the state will then use its market power and determine, can it buy something better for this relatively low-income group of folks, both in terms of cost sharing and benefit package, than would otherwise be available to them through the exchange. And I'm hopeful the answer to that is yes, because this is still a pretty low income group where the state's power in the market may be sufficient to enable the establishment of a better option. But this is something the state will have to decide over the course of the next year or two, pass legislation, and competitively bid it, as is required by federal law. Now, if we decide to offer a basic health program, I want to talk about legal immigrants. As you know, federal law does not permit federal Medicaid to pay for legal immigrants who have been in this country for less than 5 years. New York, as a result of a court case, covers legal immigrants with 100% state dollars. So New York covers legal immigrants who have been in this country for less than 5 years with state-only dollars under Medicaid. We could move all of these legal immigrants into the exchange, because while Medicaid will not cover 5-year immigrants, the exchange will. Now, we have a huge budget gap. If we move our legal immigrants into the exchange or into the basic health program, we would save state dollars, and we would substitute federal dollars for state dollars. There's a legal question about whether or not the state would still be on the hook for certain additional benefits based on the Aliasa court decision. But in any case, by taking legal immigrants out of Medicaid and moving them to the exchange and or a basic health program, we can save state dollars, and it's something we need to be attuned to. And again, this comes back to, as we put this together, we need to have continuous coverage from Medicaid to basic health plan to subsidized plan to non-subsidized plan, and that continuity or seamlessness occurs through the exchange. That's why we need to get the exchange up so we can think this through. Oops, I think I went backwards. No, I did this one. Now I'm definitely going backwards. Okay, so now federal law says that we have a new income counting rule for Medicaid. And it's the modified adjusted gross income, but it only applies to those who are under 65 and non-disabled. So, there's a question that's going to always be out there. So what do we do with individuals who are over 65 and disabled? We have separate rules, a separate infrastructure. Does this make any sense? Is there some way to start to integrate what's commonly referred to as the non-managing population into the same systems and standards? May not be the most pressing issue today, but we're going to have to address it. So for the under 65 and non-disabled, the MAGI population, we will move Medicaid from a net income standard to a gross income standard. In fact, the legislatures authorized that in 2009. It has not been implemented yet, but as part of implementing federal reform, it will be implemented. As you can see, Family Health Plus and Child Health Plus already use a gross income standard. States may not impose an asset test. We have already eliminated the asset test in New York. Takes one controversial issue off the table. Federal law says no asset test. We will need to develop, or the federal government will develop, a single streamlined application form to apply for subsidy and for coverage. Remember, Medicaid is both a subsidy and coverage, and an individual comes in, they will use one form to file for that subsidy. Federal law says no wrong door. So we can't have the Medicaid door for Medicaid and the subsidy door for the above 133. It's no wrong door. Whatever door you come in through, we must, as a state, determine your eligibility for subsidy and facilitate your enrollment into coverage. Here, federal guidance will be key. There are a number of open issues that, depending on how federal government comes in and opines, will really dictate the degree to which we can facilitate enrollment. One of the biggest is the issue of point in time. For a subsidy, a tax credit for the individual between 133 and 400, they will be able to use their tax return will a Medicaid beneficiary likewise be able to use their tax return, which is not does not necessarily reflect income at this point in time. And it is very important that CMS issue guidance allowing states to approach the point in time issue in the same way for the individuals above 133 as below 133. And that's awaits federal guidance. It's all about the systems. Everything is about the system. So the goal of federal reform is the system does the work, not the individual. And I sit on a committee at HHS to recommend to the Secretary, and the Secretary's accepted our recommendations on standards for the electronic enrollment into subsidies and into plans. And the word that I hadn't heard before that was used in all these committee meetings, and it was absolutely one of the most fascinating committees I've ever served on, is consumer mediated. This is about the consumer. The consumer owns the data. And there are a lot of IT words that don't roll off my tongue, but this is really all about a system that supports the consumer in accessing coverage, and there is a back-end interface between the exchange and the federal and state agencies that have the data, so that the verification of income and citizenship and social security number are done through an electronic interface where the information is obtained and maintained so that the consumer can use it again to renew coverage and ultimately use it to enroll in other programs outside of the matrix of health insurance programs. Now, this is one area where New York is not ahead of the game. Our current system for health, for Medicaid, is not even owned by Medicaid. It's one of the things that drove me nuts. It is in OTDA. It is a patchwork of systems that have been put together over decades. They are not efficient. There is no electronic support, no electronic decision-making, no intelligent decision-making. One system, the CHIP system, doesn't talk to the Medicaid system. The Medicaid system in New York City, right, Mary, doesn't talk to the Medicaid system in the rest of the state. It is insane. Now, we have the statewide enrollment center, which of course took too long to get up and running for the procurement process in the controller's office and the like, but it will help us move the system, but we have a lot of work to do. And the first step that we have to do is we have to do an assessment of what we have. What are our existing capabilities, and how do we build and procure a system that will facilitate coverage for individuals from 0% of the federal poverty level up to 400% of the federal poverty level, and then ultimately support the other exchange functions, which include, among other things, determining an individual is exempt from purchasing coverage, because to do so would require a greater percentage of their income than is otherwise required. So it's a lot of work to be done here. So now let's talk about it on the ground. I think I was thrilled, and I've said this to everyone, that this year the legislature passed a bill authorizing New York State's Department of Health to develop a plan to take over the administration of Medicaid from the counties. And if you think about what we've just been talking about in terms of an efficient and effective system that relies on IT, that relies on a system and relies on rules that are consumer friendly, it's time that we really rethink and redo what we have. What we have was created in the 1960s when Medicaid was welfare, and Medicaid was run by each of the welfare agencies in each of the counties. IT didn't exist. and now everything has changed. So this is a mammoth task and enormous opportunity, but now is the time to do it as we think through the role of the health exchange. Now that is not to say there will not be individuals who will need local assistance. And that doesn't mean that we can't have local or regional assistance, but the overall system should be statewide, it should be electronic, and it should be the same whether you live in Onondaga County or in Brooklyn. I have a lot more to say. I don't know what's the point. Okay, I'll do this really quickly. So we'll do a great job, but we'll still have a lot of New Yorkers who are uninsured, starting with, of course, undocumented adult immigrants. We cover undocumented children through our Child Health Plus program. So one of our goals has to be to preserve Medicaid disproportionate share payments for hospitals. Now, DISH is federal support through Medicaid, but it's not for Medicaid beneficiaries. It's to support hospitals that serve disproportionate numbers of uninsured and underinsured patients. And in New York, we also use our DISH funding to cover bad debts. Now, this should be 11.7. The total federal funding for DISH in 9-10 was $11.7 billion, of which New York received $1.7 billion. Between 2014 and 2019, federal DISH dollars are going to be cut in half. So since New York is probably the largest DISH recipient in the country, we have to think hard and long about how our DISH money is spent. We spend in total just over $3 billion. Our hospital indigent care pool is about $1 billion, and that's a DISH payment. So we really have to think, we don't want to get killed on this. So HHS has to come up with a methodology to cut DISH. And the largest reductions go to states that have the lowest uninsured rates. Well, we can't really influence that. Have the lowest levels of uncompensated care, excluding bad debts, and do not target to high volume Medicaid. So what we have to be able to do, and here's where we need to do some work, we don't know what our uncompensated care numbers are because of the way we calculate indigent care now. And we still do it, and I've been on a tear about this for 3 years, but it's still based primarily on accounting losses that we can't tie to units of service provided to uninsured patients. However you want to define uninsured. We've got to bring a level of transparency there in order to defend our formula. And we have to be accurate, we have to get it right, but we've got to bring a level of transparency there. Now, we can decide, remember, when they cut federal dollars, we still have the state dollars. We could make decisions to move the state share into rates. We could decide we need to pay more for OB because we don't have enough OB services in the state. We could move the money into rates where we will get a higher match because DISH will be subject to a 50% match. We move it into rates because of the enhanced match for childless. The matching rate goes up, and we know payment rates are the best way to drive care. I like that, but we got a problem, folks. We can only move it into rates if we have enough room under what's called the upper payment level, the UPL. But New York this year and next year is going to be taking DISH dollars and moving them and making them UPL payments. Now, I know there are only about 3 people that know what I'm talking about. But if we move DISH payments to UPL payments, you will not have enough room to move up rates. And that, to me, is an opportunity foregone. And so we need to think hard and long about how we spend our dollars. Okay. So, and Dick talked about this, but while the first goal of the ACA may be coverage, right behind it is payment and delivery system reform. And it is tied to reducing expenditures in Medicaid and Medicare. So I would suggest to you, from the point of view of New York, payment and delivery system reform is both a health reform issue and it's a cost containment issue. I hate across-the-board rate cuts. My budget friends, I understand that it is an immediate savings. But it is, in my view, and it's easy. Politically, it's easy. You treat all sectors the same. The nursing homes are treated the same as the hospitals. We're treated the same as the home health agencies. And within each sector, every provider is treated the same. And you get your money right away. It's so damn short-sighted, though, because all sectors aren't equally important to Medicaid beneficiaries. All sectors, we want to drive care in certain ways. We need to think about where we put our money. We need to make hard choices about where we cut. And we need to make distinctions among providers, among efficient and effective providers and less efficient and effective providers. And that's really hard to do in a political process. It really is. But then we default to across-the-board rate cuts, which hurt everybody, and don't change how care is delivered in the short run or the long run. So can we bite the bullet? I don't know. But that's what I think we need to do. And it starts with getting our fee-for-service payment methods, right? As I was saying to folks before this meeting, on inpatient and outpatient care, we are light years ahead of most states. We really have top-of-the-line payment methodologies for hospital inpatient and for hospital and clinic outpatient. We're really ahead of the nation. On long-term care, there really is no state that's quite figured it out. And I continue to think this is a real challenge for New York, because we've got to get our payment methodologies correct. If we don't get them correct, and on the acute care side, I believe we have, how are we going to do multi-payer demos? That's what so much of what federal reform is about, multi-payer demos. And to participate, Medicaid's got to be an intelligent payer. Finally, and I'm just about done, there are a multitude of demonstration programs in the Affordable Care Act and billions of dollars available to states. And one of the things I love most is a lot of the people who are controlling all these dollars are former Medicaid directors of other states. So the Medicaid can play, but in order for Medicaid to play, we've got to have we have to have the ability to be flexible and the staff that is focused. And both of those are a challenge because the Department of Health has no flexibility today in how it sets reimbursement methodologies. And focus means enough staff to pull it together to be able to bring New York to the table. We are well positioned to get the medical home multi-payer demo because of the Adirondack medical home. But it took all of us 3 years to bring that up and to position us. And we won't have 3 years to take advantage of these dollars. So, see, one more slide. I can just figure this thing out. Yeah. So we have to pull it all together by 2014. It's a huge opportunity. Again, we are in the forefront of states. We have an interagency cabinet. We have a stakeholder advisory group. But like other states, we have limited human and fiscal resources. We need outside expertise. I don't know what we do about procurement rules. I understand why they're there. I understand why the legislature is reluctant not to notwithstand them, but how are we going to do all of this and be up and running in 14? We're going to have to take a hard look at that. And the other thing, I've had the pleasure of working with the New York State Health Foundation for the last 6 or 7 months, and they are on a course to provide some level of assistance in New York in making these decisions, including the report I did with Melinda Dutton and Patty Buzang on the roadmap for New York. So we have some things going for us, but it's going to be an interesting 4 years. Thank you very much.